Well, the hospitals have always, I mean, the hospitals traditionally haven't innovated a lot on the services side. They've been rapid adopters of innovation, but the innovations come from other places traditionally. If you look at sort of the history of healthcare services innovation.
I have a little different perspective on this bundling. First of all, I'm sad that we may be backing away from ACOs, because the purpose of the ACO, from where I'm sitting, was really to take accountability for management of the health of a population. When we get back to bundles, especially for preference-sensitive care or elective care, go back 20 years, 30 years to Regina Herzingler and Focus Factories. You can become very good at doing hip replacements and knee replacements, including a lot of unnecessary ones. So if you don't make the system accountable for the appropriateness of the service, it kind of undermines the whole purpose of the bundle. You produce them very effectively. Where bundles, I think, work best is where there isn't a lot of preference-sensitive or physician-driven utilization. So MIs, hip fractures, cancer care. I think those make perfect sense, because you can still manage the health of that isolated population without a lot of demand-driven, whether it be physician or patient-driven use.
But you can argue you can do that in oncology as well. There's certain cancers, certain settings where you could push a bundled payment down to the physician, where their approach is more standardized, and then you can allow patients to fall outside, or the physician to fall outside the bundle if it becomes more complex.
Sure.
But there are places where you could offer a bundled arrangement. But you seem to think that they're going to try to move in this other direction, at least with respect to oncology.
I do.
Yeah.
I do. And my time horizons are kind of smaller, for the next 3 to 5 years, I think, especially because oncologists, I think the other piece that's different in all these settings, remember, orthopedic surgeons have actually been kind of exposed to this bundled concept for a while. I mean, the CMS has done demonstrations in this area. Yeah. There's private sector orthopedic bundles that have been around for over a decade. So the difference here is that oncologists, particularly, let me be even more specific, medical oncologists, surgical oncologists, radiation oncologists, they have not been exposed to this type of risk. So I think that CMS, and let's not just say CMS, I think all payers acknowledge that for a population of clinicians to do something differently, they need a different type of exposure, and it's going to come, I think, from what Priority did with the oncology medical home, and I think those are the ways that it'll go forward.
I was going to just say, too, there's certain areas where it makes all the sense in the world in terms of where you can do bundles. So you look at what MD Anderson is, head and neck, you look at some other things, what Dr. Pecor is doing in New Jersey. But the problem is, from the Medicare side, it's usually black and white.
Yeah, right.
They don't have the ability to say, okay, we'll selectively bundle over here, selectively bundle over here. So although that can be done,
you can't treat beneficiaries differently.
That's right.
And we get back to statutory.
So you have to do it. My point is, Scott, you have to do it for everything. Right. So now you're talking about every different cancer type, every iteration, and I don't think that's anytime soon.